topic for me, and I'm sure it is for you. I'm the executive director of the Ontario division, and I'm very happy to be here. My name is Ahmad Zabib, and I want to introduce Dr. Jean-Olivier Paquin. Hopefully, I got the name right. Yeah, he's a resident in orthopedic surgery last year. He's a graduate of the University of Ottawa's Faculty of Medicine. He started his last year of residency training in orthopedic surgery at the University of Montreal in July. He's a sports enthusiast and with a real passion for treatment of sports injury. Dr. Paquin also studied kinesiology at the same university for 2 years. During that time, he played for the Carabins football team. So, a surgeon, an athlete, what more do you want? Dr. Paquin, over to you.
Hello again, thanks for coming. Hopefully this helps you with the understanding of your pains you have in your knees, but be ensured that although this is a talk about the knee, I'll be pleased to answer any questions about any joints or any conditions you have that I can provide information for. So let's get this started. So the plan of the presentation is very simple. First, I'm just going to talk to you about what is osteoarthritis, what you need to know about this condition, the management of this condition, and if this management fails, what do we need to do? What can we offer you in orthopedic surgery? Talking about the surgical treatments for that condition. So what is osteoarthritis? Little anatomy class to get it started. The knee is not only one joint, it's a very complex joint that is formed by two different joints. The first one being the one we think about between the femur and the tibia, but there's another very complex joint forming the knee. It's the patellofemoral joint formed obviously by the patella, the kneecap, and the femur, which at times can cause very debilitating pain and be a source of problem for us. The knee, as I said, is a complex joint. It's not only an hinge. There are very much more to know about this joint, very microscopic motion that complexify the surgery about this joint, much more complex than the hip. So what is osteoarthritis? It's not a disease. I don't like to call it a disease. I like to call it a process or a condition. It's multifactorial, that's for sure, and it's progressive. It affects 1 in 10 people, and we know that the incidence of knee replacement in the United States right now for 10,000 people is 5 knees, 5 knee replacement, and 60 hip replacement by 10,000 people. And this tends to be 6 times more in 2030 for the hip and for the knee. So it is a prevalent condition. Main causes of osteoarthritis: first, following an injury. Let's say you had a fracture when you were young. The cartilage, the articular surface the conformity was changed. Then you're more likely to suffer from osteoarthritis 30 years down the road. If you have an excess weight, you put more stress on your joint. That's definitely what I tell my patients every time they come for osteoarthritic conditions. Try to lose weight. It's the only way to reverse the pathology, to actually stop it and not progress to the surgical treatment. The only way, and I'm going to repeat this many times during my presentation. And lower limb alignment issue, people can be, they can be born with deformities, and sometimes they are more likely to get osteoarthritis. What is osteoarthritis? Cartilage is the membrane that covers the bone inside of the joints. When you get into a joint, you see healthy cartilage. It's beautiful. It's white. It shines. It's something very special. And when you get into an arthritic joint and the cartilage is degenerated, you see exposed bone, and that's the surface that's causing the problem. What's the difference between osteoarthritis and arthritis? Very important. Arthritis is the word for every painful joint condition. It can be, polyarthritis, rheumatoid arthritis, psoriatic arthritis, juvenile arthritis. Osteoarthritis is the mechanical process of a joint that is degenerated by, as I said, post-traumatic conditions or just effect of time. Are these symptoms familiar to you? Joint stiffness, being waking up in the morning with a stiff knee or stiff hip. When you sit down for dinner, for a long dinner, and you stand up after, you feel very tight. You feel your knees are stiff. That's the first manifestation of osteoarthritis. Pain, as I said, in the morning when you wake up, your joints are stiff and they're painful. When you touch, when you palpate your joints, it is actually painful. And secondary to that, it relates to the stiffness, but you lose flexibility. You're not able to straighten your leg. You're not able to flex as you were able to do before. Sometimes it affects sleeps as well. People wake up at night with pain. These patients, they come to us and they almost, kneel to ask us to do something for them, because when you don't sleep at night and you're in pain during the day, it is a very difficult journey. When people see bony lumps around their joints, it's called osteophytes. It means that the joint is trying to get stabilized because of this loss of conformity associated with cartilage, and the joints is creating new bones, little bone spurs to stabilize the joint. Means it's a well-installated process. And again, discomfort after temperature change. We hear that a lot, but it's actually true. Our patient with osteoarthritis are better than barometer to tell us when the temperature is going to change. So, as I said before, osteoarthritis is more related to the mechanic part of our body, the effect of time, but there are also systemic factors. You can have a marathon runner that comes to you with an osteoarthritic joint, but you can have also a morbidly obese patient coming into your office. These two patients have a very different background, but they're both affected by the same condition. So you have to know that age, sex, genetic, ethnic origin, and bone density are very important factors in the progression of arthrosis. Local factors, they're associated with the mechanic. Are you overweight? Are your legs not well aligned? The joint mechanics inside of your knee. Did you get an injury that implied, that involves a fracture inside of a joint that can be generating some arthritis? Sorry. I'm inviting you to have a look at the picture right on the side here when I'm talking about joint or knee alignment. As you can see beside my red arrow there, on the exterior side of the knee here, there's a black radiolucent line that is filled with cartilage, because cartilage is not seen on x-rays. The x-rays are going through the cartilage. So this little space that you see here, that black line, is filled with cartilage. It's a normal knee. Look on the other side what's happening. There's no black line, there's no cartilage, it's bone on bone, and that generates a lot of pain. So in summary, osteoarthritis is a degenerative disease and remains one of the main causes, if not the main cause, of functional disability. So you have healthy patients not being able to go to work, to enjoy life, because the pain they go through with their degenerated joints, and that's very important. The government of our different provinces around Canada like to pay for joint replacement, because you have citizens that are prone to go to work, they want to have an active life, contribute to society, but they can't because of their pain, and we can change that with the surgery. We're good to make an orthopedic surgery. The progression of arthrosis as well, as I said before, greatly depends on the modifiable factors that you have control over, with on top of this list being your weight. You have to lose weight if you want to get rid of your pains. So now, what can we do for you if you have such a condition in one of your joints? First, we have to establish a diagnosis. That's always important in medicine. We like to know what we're treating, as opposed to other practitioners that don't tend to work this way. We always make a diagnosis before we treat a condition. So first, history. Usually a patient around 60 years old comes to your office with new, joint pains they have, and without any history of trauma. There are two types of patients. You can come to our office with a very recent accident, or just new pains you're going through and you don't know why. So when a patient tells me that he feels, a new pain that came to his knee without any history of trauma, there's a little flag up in my head thinking about arthritis, about osteoarthritis. And I look at his walking pattern, at his gait. How is he walking? Are his legs in cowboy, or are they very straight? And then I touch his knee. Is it painful? I palpate every region of the knee, the femur, the patella, the tibia. Is it painful? Where is it painful? And then I see the range of motion. As I said before, are you able to straighten the leg? Are you able to flex your knee? Usually people with osteoarthritis are not able to do that. And then specific manual tests to assess the joint, to make sure that the stability of the joint is not compromised, because that's very important if we get to a surgical treatment. Then the imaging, the x-rays. Usually, as I said, people come to our office, never had an x-ray before. So we always use an x-ray to make the diagnosis of arthrosis. It will not tell us how the patient feels though. Okay, some people have very, very bad x-rays and they don't feel any pain. Some people have great deals of pain, but their x-ray looks normal. So you have to relate more on how the patient feels to decide what to do instead of looking at the x-ray. The x-ray is just a tool to make sure you have the good diagnosis. Again, I invite you to have a look at a little knee here on the left image. Again, we see that, very narrow joint line here with no more cartilage. Okay, and you have to remember that there's a meniscus here that is completely pinched, so a great deal of pain can come from that joint, and that's an healthy knee. See both sides that is filled with healthy cartilage. Again, as I said, I talked to you earlier about little bone spurs forming in the arthritic joints. As you can see here, there's a little osteophyte forming. You can only imagine how this patient feels when he flexes and extends his knee, and this little bony spur is rubbing on the cartilage surface. And you have this, again, size of the joint line on this side is much more narrow than if you have a look on the other side here. So these are the cardinal signs of osteoarthritis. Again, as I said before, there are two joints inside the knee. Sometimes the problematic joint is the patellofemoral joint. See, we have the femur here, we have the patella. We don't see many changes in that part of the joint here, but look what's going on the patellofemoral joints. There's no more space. All the cartilage there is torn, and that is a major problem, creating a lot of pains to the patients. Diagnostic imaging. Here in Quebec, we have access to private facilities for diagnostic imaging. And very often, patient comes to our office with the smile on their face, doctor, I did my homework, here's my MRI. So I went to the private clinic, paid a very significant amount of money for that MRI. I take the CD, I say thank you very much, put it on the side of the desk, and I don't even look at it. There is no valuable information to get from an MRI with a patient that's 50, 60 years old and is complaining about degenerative pain in their joints. Okay, MRI is for soft tissue evaluation, traumatic pain, young patients, not for assessing bone. It's not a good modality for assessing bone. We need a simple X-ray, as I said before. So what do we do? If you come to our office and you have degenerative osteoarthritic pain inside of your joints, what are we going to suggest you? First thing, I'm sure you know the answer. I talked about it many times already. Please lose weight. As I said, it's the only way to stop the process of wear and tear inside of a joint and to avoid, at the end of this long degenerative disease, to get a surgical treatment, to have a knee replacement. So if the patient comes back, lost weight, but still has a great deal of pain, then we have to go ahead with medication. The ones that we tend to prescribe are, Tylenol, okay, and NSAIDs, which are anti-inflammatory drugs. rarely, very rarely do use opioids like Dilaudid or morphine to treat that pain. We don't want to make our patients dependent about a drug before any type of surgery. We send them in physio, and then we can go ahead with infiltration, injection inside of the joint to remove the inflammation and make them feel better. There are two types of different injections we can make. The first one being corticosteroids that will remove the inflammation, or second, viscosupplementation. In our guidelines in orthopedic surgery, viscosupplementation does not have a very clear indication. But what I can tell you, some patients use it every year and they rely on that to be able to function. So there's definitely a room for that for certain type of patients. So what are the difference between these two injections? Viscosupplementation is WD-40 that's made for the body, okay? You inject that inside of the joints, it replaces the synovial fluid and makes your joint feel better. It can last for, a very great amount of time. Sometimes patients feel better with one injection for a year, a full year. So to me, that there's room for this injection. Although it's very expensive, some insurances plan cover for that. If not, it's around $400 for one injection. Corticosteroids are always covered, okay? And they can be administered a few times a year. I like to tell patients that if I inject their knee with corticosteroid and they don't get relief for more than 4 to 6 months, if they get relief for, let's say, less than 4 to 6 months, then I tend to stop that treatment and suggest to go ahead with a surgery. Again, reducing stress on the joint, correcting the activities you make, maybe give up on this jogging you were doing and start to go swim, or to start and buy a bike. This is much less stress for your joints when you do this type of activities instead of jogging. And again, lose weight. Correcting knee alignments, we had a little discussion before. This is related to orthotics. You can now buy orthotics that are made to correct this deformation you have in your mechanical axis. If the knee is not straight and one compartment of the joint has more stress, not significant change in your mechanical axis, these orthotics can help. Again, some patients are very happy with that, but there are very limited evidence because one, you have to be the correct size for these orthotics. If you're too big or too small, they won't fit you and you won't have the benefits from that. So, but there is definitely room for these orthotics to correct the knee or the lower limb alignment. That is the slide that's very important to insist on the fact that a joint is a dynamic entity. Okay, we can have an X-ray that's totally normal, as I said before, but a patient with a great deal of pain. And this just tells me that the X-ray is a static image of their knee, but when they flex, they do their everyday activity, then if they have pain, there's a problem with their joints. So now we tend to send them in kinesiology and have a biomechanical assessment of their joints while they're doing their activities to understand better, the problem they have with their joints. So summary again, treatment options. What do we do with patients who go through such pains? We send them in physio. Physio is a very important partner in our job. They can help you to reduce the pain you have, the inflammation, straighten your limbs, get back this flexibility that's lacking with this condition. Dietitian, again, for the reason I specified many times before, to help you lose weight. We do activity to stay healthy, and we control our diet to lose weight. It's the only way we know now to lose weight is to control what you're eating, what goes in. Kinesiologist, again, specific exercise, things you like, things you're going to do to keep your knee moving. Orthotics, we talked about it already. Education, because you are the center of your problem, okay? You need to be the person taking care of that. Nobody will do it for you. Self-management is the same, and to stay active. We said that many times before. Again, that's just a little slide to show you that the overall management of this condition now in 2016 involves a lot of professionals, and all these people have a very important part in treating your pain. Not only the orthopedic surgeon is important. As I said, the government, the different province, but even the federal governments like you to be informed about what is arthrosis, osteoarthritis, because this condition is very, very important for them, because if you're not able to go to work but you're healthy, then you don't contribute to society. So they like to give money. It's a good investment for them to invest in that field of medicine, because people go back to work and start paying taxes again. So education is the key to success. That's why you're here today. I'm very happy about that. Understand your pain. Go see your family doctor. Go see your kinesiologist, your physio. Feel empowered about this condition. If you're able to do the things you have to do, then you might avoid the surgery. In summary, as we said, pain management on its own does not reduce the progression of the disease. The only thing that does, I think you have the answer, is to lose weight or to modify the activities you do. Osteoarthritis is a degenerative disease. The pain will progress. The things you're able to do are going to go down if you don't take good care of your condition. As we said, this goes back to the first line. Progression is determined by modifiable factors, and you must take them into account if you want to feel better. So finally, the heart of our presentations. What do orthopedic surgeons have to offer you when all these things we discussed failed? What can we do? So first, okay, osteotomy. That's not a knee replacement. That's a correction of the knee alignment in surgery. So sometimes patients come to your office, they're young, they have a prevalent condition called osteoarthritis, but we don't want to offer them a knee replacement only because they're too young, and we think that we might do something better than changing their knee. The indication, as I said, is a young and active patient that is ready to go through a complicated procedure, complicated and long, difficult post-op period, that will feel willing to follow a very strict program of rehab. This is not for everybody, okay? But the advantages of that procedure is that you don't change the joint, okay? You leave all the ligamentous structures in place, and these people are able to go back to a greater deal of activities. They're able to go back to jogging, playing hockey, playing soccer, change of direction activities, because the native joint is still there, okay? As I said, it's not for everybody. Very rarely do we do that procedure now, because we know that the postoperative period is very difficult. You can see the image here, okay? So the bone cut is here, okay? The affected compartment is on this side here, okay? So we change the mechanical axis of the limb by making a cut inside of the bone, putting a plate to hold the cut out open, and then we put the pressure on this side of the knee now, okay? This will not last forever, okay? It's made for young patients. We said young patient means greater life expectancy, so chances are in 20 years after their surgery, they will come back and they will need a knee replacement as well. But this can give them a great amount of time without a knee replacement, okay? Then, total knee prosthesis, okay, knee replacement as opposed to unicompartmental prosthesis, okay? Again, different indications and different post-op. First, we call it the unicompartmental prosthesis, will only replace the affected compartment. As you saw before on the pictures I showed you, very often is there only one compartment that's affected between the tibia and the femur. Although you have to go look at your patella again, as I said, there's the third compartment that is sometimes affected. When this compartment is affected, there's nothing you can do. You have to do the full prosthesis, okay? So that's the reason why we only have about 5% of our patients that are good candidates for the unicompartmental prosthesis, okay? And I'm talking about surgeons who are doing a lot of uni. Only about 5% of our candidates are good candidates for that surgery. The benefits of that surgery, the unicompartmental, is that the post-op period is much more easier. We don't, or very rarely do we send them in physio. We just need, to have the bone cuts, the scar, these things when they're healed, patients go back to their activities. Okay, we don't force them to do physio. They don't need it. Okay, disadvantage is the lifespan of these implants. Okay, historically, about 90% of the prostheses were still good after 10 years, but a drastic, loss of implants doing their job. Let's say it this way, after 10 years, and between 10 and 20 years. Okay. And now total prosthesis. That is the thing we do, almost every day in every hospital in orthopedic surgery. Okay. You see here, both compartments are replaced, and the patella here is resurfaced. Okay, the sill patella, we tend to forget about it, but it's a very important part of the surgery. Okay, the way the surgeon takes care of the patella is, very important, because that's where, patients that are not satisfied with their surgery are going to complain about. Most of the time, it's problems with the patella. Okay. So, total prosthesis, what are the indications? As I said, a knee that's affected in 2 of the 3 compartments, a patient that goes through a very bad pain, who's waking up at night, not able to do the things they like, okay, then it's a good surgery for them. We aim to reduce the pain with that surgery, okay, but very rarely are we able to offer a completely pain-free joint, okay? They are, with that surgery, it's a very good surgery. Trust me, patients are happy with that surgery. They come back, they ask us to do the other sides, but you have to understand that about 20% of the times are we able to offer patient a joint that is completely free of pain. This is not the same as the hip. With the hip, we're even better. It's about 80 to 90% of the time do patients feel absolutely no pain with their replaced joint, okay? But it's a bearable pain. Patients are very happy when they went through a very bad pain, okay? And you're still able to do a great deal of activities. Some patients are able to do alpine skiing, although we don't recommend to go back to alpine skiing. Some patients are able to do that. Walking on an uneven surface in the woods, going for cross-country skiing, biking, all these stuffs. People with knee replacements are able to do, and they're very happy with that. The post-op is difficult with a knee replacement. It takes about 3 months to feel better, okay, to understand why you had that surgery. When people come back at 6 weeks, they start usually, because we see our patient, they stay in the hospital for about 3 to 5 days, and then they go either back home or in rehab for a few weeks, and we see them back around 4 weeks, 4 to 6 weeks, depending on the surgeon. And when patient comes at 4 weeks, they still have, significant amount of pain, okay? But when we see them back at 3 months, then they come back with their smiles and they understand why they had that surgery. It's a painful surgery. A knee replacement is much more painful than a hip replacement. The disadvantage of the surgery as well, the post-op, as I said, but also it's not a final decision, because we're able to, offer patients with a problematic prosthesis that was put in place, let's say 20 years ago. That's wear and tear with the effect of time. We're able to go back and make a revision, but that's a very complex surgery, and not every surgeon is able to do that. Okay, so that means that it's a complex surgery. You have to really be convinced that this is what you need. Your surgeon will offer the surgery, but this is your choice. You have to make sure that you understand what you can hope for in terms of pain relief, activities you'll be able to do again, and that you're willing to go through surgical risk, because with every procedure, you have to accept that there are some chances that the surgery does not go the way we want it to go. Thank you very much. I'll be more happy than answer all of your questions. Questions, anybody?
How long are we? how long are knee replacements lasting now?
It's a very good question. The implants are much, much more better than they used to be. Okay, so about 90% of the knee replacements we make now are still in place after 10 years, and about 80 to 85% after 20 years. Okay, but you have to remember that to evaluate a knee after 20 years, it means you had it put in place 20 years ago. So the implants we use now, we hope that they're going to last much longer than that. So I cannot put a precise word. Every patient is different, but you
have to
can
wait
hope
20 years.
more than 20 years. You can hope for more than 20 years. It depends. Sometimes you have an immune reaction to all the debris created by the effect of time. Then you need to remove the old poly, because in a knee you have the bearing surface is between metal and polyethylene. Okay, and these debris sometimes they can create defects inside of the bone. So you need to remove that. You need to fill the voids inside of the bone. That's the complex part, and you have to change the implants. So you can have a revision surgery. But this revision surgery is a even harder post-op, and you have to find a good surgeon to offer that surgery, because these surgeries are very complex. Exactly. That's why you need to wait. Again, this is getting less and less true. We tend to offer the surgery to younger patients because we feel that our techniques and our implants are evolving, and that the lifespan of our implants will be better than what it is right now. And we want to offer a patient a good and active lifestyle at, before 60 years old, instead of waiting later on in life and have them to, suffering between 10 years that can be productive years. And we tend to offer the surgery earlier now.
Hi, I'm the technician for the webinar. I'm just relaying two questions that we've received.
Very good.
So the first question is from some guy, 30-year-old guy, and he says, what will be the pros and cons of a joint replacement versus joint fusion surgery? And if joint replacement is an option, could a fusion be performed when the replacement fails?
Very good question. So young patients sometimes have osteoarthritis, and we need to help these patients as well. We know that we cannot do an arthrodesis. Arthrodesis is the process of fusing a joint. Okay, we cannot do arthrodesis on both sides. Okay, because patient will not be happy with that. We can do it on one side, and patients are fairly happy with fusion on one side. They're still able to walk, and a knee replacement after a fusion is much more complex than just a primary surgery, a primary replacement. So we have to decide whether we do a fusion or a joint replacement. And if we go ahead with the joint replacement first, there are many more things you're able to do. Okay, you're more better function, many more things you can do. But the problem is always the lifespan of the implants. At 30 years old, chances are that around, you're more active at 30 than you are at 60. So the implants probably have a smaller, shorter lifespan when you have a joint replacement at 30 years old. So chances are you're going to need one, maybe two revisions in your life with complex surgeries, difficult post-op, and maybe not, the result you would hope for with such complex surgeries.
Thank you for your answer. And we have one final question from a 68-year-old woman asking, she's looking for information on spinal surgery for scoliosis on a 68-year-old woman with increased pains. So do you have any pointers that could maybe help her out?
Spine surgery is a field of orthopedic surgeries. We're all trained in taking care of spine conditions. Scoliosis is one of them. For this lady, it's probably degenerative scoliosis. Osteoarthritis inside of the spine can lead to scoliosis, and some surgeons will be more than happy to answer all of her questions, probably in university settings, because this is a subspecialty of orthopedic surgery. So she would need to consult her family physician and ask this person to send her to a university hospital with a spine service.
Thank you for your answers.
Pleasure.
So what's your advice as an athlete for people who want to be very active? I'm into long distance running, for example, and I want to make sure I don't get to a point where I need a knee replacement. What's your advice for me, or for all people who want to be active?
This is a very good question because people are more and more, enlightened on the good sides of physical activity. And a very popular activity in 2016 is running marathons. Everybody thinks they're marathon runners. I tell these people that marathon is not for everybody, okay? Because this can be a problem, people coming to your office at 30 years old now with knee pain. I don't say that these people have osteoarthritis, but coming with untraceable knee pain, they're usually marathon runners. So try to aim for activities that you can really train well for. If you want to run 10 kilometers. Don't go for the marathons in the first year you started to run, because this can lead to knee problem. Making the relation between marathon running and osteoarthritis 30 years down the road is very hard to establish. But I still tell people to try and find activities that they're well prepared for and that they feel good about. Absolutely. Go gradual increase. Not everybody is made to be able to go from scratch, then to run a marathon inside of a few months. This can lead to very difficult, condition, very hard to find pain around the knees. It's a new things I see in clinic. People starting to run marathons and having pain around their hip or their knees. That would be my advice. Yes, there is one.
Could you could you tell me good exercises for osteoarthritis knee? You mean swimming will be good?
It's a good question. If you want to stay active, a kinesiologist is the person to see.
Yeah.
That will give you a program that is made for you, things you like, things that you are going to do, because if you don't like the activities that we prescribe you, you're not going to do them, so you'll have no benefits from that. But all the activities that will keep your knee moving without stressing them are good activities. So as I said, swimming is one of them, biking is one of them,
Yeah.
cross-country skiing, if you like that, I would think that this would be a good activity.
But you were talking about after a surgery, knee surgery.
Yes.
You were talking about ski, and the same person can skate too.
You mean, is skating something you can do with a knee replacement?
Yeah, after a knee replacement, skating.
It's probably in the same category as alpine skiing.
Okay, fine.
Probably not recommended by your surgeon,
No.
but probably something that if you're happy because you go skating once or twice a year,
Yeah.
if this makes you happy, then that's why you get the knee replacement, because you want to have a very active, happy life.
Yeah.
So I would say, yes, go skate if this makes you happy. That's why you accept to have such a great, process, a great decision to make in your life, because you want to be functional, you want to be happy. Then if skating is something that makes you happy, then do it.
Okay.
But know that we don't recommend it.
Okay, right. Okay, thank you very much.
Any other questions? No? Feel free. You want to use the mic?
What do you think of the Durolane injection?
Durolane is a visco supplementation, as we discussed. Okay, so as I said, our guidelines are not clear about this. All these formulas we have now are called visco supplementation. But as I said, if your insurance plans pays for it and you're willing to try it, some people are very happy with it. So I don't have any issues with that. Pleasure. Great. Thank you.
So on behalf of the society, I want to thank this speaker, Dr. Jean-Olivier, and I want to thank all of you for being here and for taking the time to be part of our community. I'm going to ask one last favor of you. You have evaluation forms that are part of your package, and that means a lot to us when you actually tell us what you think and how can we do things better. And compliments are also welcome. So please feel free to fill out the form and drop it in the box. And for those of you online through the webinar, I believe there's an option for you to submit your evaluation as well. Thanks again, and we look forward to having you here next year as well. Thank you.